Yes.
Excellent. All right. So I was asked to sort of talk about malaria and prevention, and Dr. Coyle, Professor Coyle, asked me to start with some epi, put things in perspective, and go over prevention, and then to also do the post-travel side, since once again travel can be both pre and post. So malaria and prevention. I have no conflict of interest, and if I talk of any off-label use, I'll point it out. So the top malaria, so remember there's 5 species of malaria that can infect humans, and the big global players really are falciparum and vivax. And you see a picture of falciparum on the top and vivax on the bottom. And it's falciparum that really accounts for the vast majority of the global mortality, especially associated with malaria. Here in the United States, making the assumption that many of us on the call today are practicing in North America and in the US, here in the United States, we have about a little over 2,000 cases of malaria each year. And unfortunately, there's a handful of deaths. And if you look at those deaths, many of those individuals did not seek care before they went overseas. If they did not adhere to recommendations or were given the wrong recommendations. And then when they came back, they were often misdiagnosed. People didn't think of malaria. And when they did make the diagnosis, often they received inadequate therapy. And so there's definitely room for improvement on this. So the CDC comes out every year with a listing of the most recent couple of years that they can analyze their data for malaria. And it's always worth looking at it just to see the trends. So I guess the first is that the overall diagnosis of malaria in the United States continues to increase. This largely reflects increasing travel to sub-Saharan Africa, and I'll show you that in the next slide. The burden in the United States largely affects the states with the largest populations, and especially those states that have large populations that travel internationally, especially to malarious areas of the world. And I know, once again, many of you today are in New York, and if you notice, New York accounts for about 15% of, New York City accounts for about 15% of all diagnosed malaria cases in the United States. Now, this goes over the 4 major human-restricted plasmodium species of malaria. And what you notice is the vast majority, at the most recent year that we have good data on, with the vast majority are falciparum and vivax. And between those two, we're up to about 90% of malaria that's diagnosed in the US. This shows us the number of direct flights from the United States to Africa. And you notice that this largely reflects the increase that we see. 85 to 90% of malaria diagnosed in the United States is diagnosed from individuals who have traveled recently to Africa. And we're just coming to the end of peak malaria season here in North America for diagnosis. And it largely reflects the travel patterns over the summer, but also the malaria endemicity and seasons at the destinations. So someone traveling back from Africa who comes to you with a fever in sort of summer or late summer, early fall, until proven otherwise, you have to think about malaria. We've already talked that the vast majority are individuals coming back from Africa. And with regard to who they are, sorry, I'm on service today. With regard to who they are, it's largely individuals that the CDC refers to as visiting friends and relatives. So these are individuals who were born overseas and are going back to visit family and friends, or recent refugees or immigrants. And many of these upfront individuals here often don't seek medical care before they travel internationally, because from their brain perspective, they're going home to visit family, et cetera. So they don't really see it as a medical risk. However, whatever malaria immunity they had as young children, once you're out of a zone for 2 or 3 years, basically you've lost your immunity and you're back to being a young child. On the post-travel side, when should you think of malaria? When somebody comes to you with a fever. And on the falciparum side, what you'll notice is within about a month after the trip, 95, 96% of people will have presented with their fever. And by the time you get to 3 months after the trip, it's about 99%. So if you have a fever in the first 1 to 3 months after an international trip to a malarious area, falciparum needs to be on your radar screen. But after that 3 months, yeah, you have to rule it out, but it markedly falls off for a likelihood. In comparison, what we call the temperate malarias, vivax and ovale, they tend to come out over the next course of the year. And that's largely because when we as a species moved out of Africa, we moved from a part of the world that had malaria year-round, mosquitoes year-round, to areas of the world where there's distinct mosquito season. So there was selection pressure for these delayed release malarias, and they quotation marks hide in the liver hypnozoite form, and they come out usually over the next year. Once you get a year out from a trip, although there's some rare cases of malaria, you're really looking at rare things at that point. This is just to remind us, I know the print is small, but this is to remind us that regarding your destination, that the risk of malaria varies. So not about 30 million before COVID, and I suspect we'll get that back there, about 30 million individuals in the United States travel to a low or middle income country on a yearly basis. But if you look at those, only about 9 million travel to malarious areas. And even within that, the risk varies greatly. There's some areas, say in Papua New Guinea, et cetera, where the risk would be as high as 10 to 20% per month if you don't take any chemoprophylaxis. The next highest is East Africa, where the risk is maybe 1 to 3% per month if you don't take anything. Then, I'm sorry, West Africa at 1 to 3% per month if you don't take anything. Then East Africa at about 1 or 2% per month. And then it falls off, Sub-Saharan Africa, other areas, Southern Africa, you're down to 1 in 1,000 or so, 1 in 100 to 1 in 1,000. If you go to Asia, many of those areas are 1 in 1,000 to 1 in 10,000 or less. And if you go to many areas in Latin America, it's 1 in 10,000 to 1 in 100,000. And this just is a numerator of how many people diagnosed with malaria after traveling to the denominators represented here. Remember that as you're approaching somebody trying to get them set for their international trip, that not only you have to worry about is there malaria at the country, but you also have to worry about resistance profiles. We'll come to that in a second, with probably the most worrisome resistance profile in this area of Southeast Asia. And remember, as part of the preacher, I mean, obviously you're coming to the end of the session for today, but hopefully you've taken into account that there's all different illnesses that someone, when they travel to an LMIC setting, might be at risk for. I guess I would underscore that as you have your practices, you really need to, especially for individuals who are at the highest risk, they're often the people who are least concerned about getting something when they travel home for their brother's wedding or a family funeral or just to see the family. So be proactive, either ask about, is there any upcoming international trip, or have in your waiting room different posters. And the Heading Home Healthy website, I'm going to refer to repetitively today, but that you can just, as I'm chatting, you can go to your phone and just put in Heading Home Healthy, and you're going to go to the webpage. There's all different resources there. It's all free. It's supported by the CDC. There's posters in multiple languages that you can put up in your clinic, waiting room, et cetera. And recognize that malaria is only one thing that we have to worry about prepping someone for international. Obviously, all these other ones are things that also have to be part of that encounter. Now, if we jump ahead to malaria, because that's what the focus of this breakout session is, recognize you really need to delve into the details of the destination, the time of year, all that sort of stuff. I'll come back to them in a second. And although we always jump to right with the pills, recognize that it's worth spending some time and having some handouts on ways to minimize mosquito avoidance and also other insect avoidance with regard to behavior, repellents, use of netting, and clothing. And if there's time at the end, we can go over that a bit, but a wonderful resource is on the CDC webpage. It lists the agents that the CDC considers with working with the FDA as actually being effective, as opposed to being sort of old witch's brews or something. So these are the agents that individuals should do. They could actually the travelers can go directly to the insect repellent EPA website and look up their products, et cetera. So there's that. There's also things, wear light cotton long sleeve clothing, sleep under netting if you're in a very malarious area, or at least have screens on the window, et cetera. All different very helpful information that you can get and transmit to your travelers. And then if we go to the meds, there's basically 7 meds you can deal with, so it's not a huge list. And probably the 3 major meds with regard to chemoprophylaxis are Malarone, that's the formal name is it's a fixed combination of atovaquone proguanil, and doxycycline and mefloquine. And those are probably the 3 primary workhorses. I'll get started with, these are not in any order of preference per se. In fact, I think it's in alphabetical order. So atovaquone proguanil is daily. You take it daily, beginning 2 days before entering malaria zone and taking it to 7 days after leaving. There's some mild nausea if you take it on an empty stomach. And if you take it long-term, the long-term expats, et cetera, after about 6 or 8 weeks or so, some people develop aphthous ulcers, but they resolve over a week or so. It costs about $10 a tablet, so that rapidly adds up. But you'll notice many of these drugs are priced roughly equivalently when you take the whole course into account. One of the nice things about atovaquone proguanil is there's both an adult and pediatric tablet. The pediatric tablet is 1/4 the size of the adult. There is no liquid suspension for any of the malaria drugs, et cetera. And like many of the malaria drugs, it's considered a category C. Your other choice for a daily drug would be doxycycline. That you start and take daily while you're going through the malaria zone, but you take it for an additional 3 weeks. You take it for 4 weeks after you leave the malaria zone. And that's largely is, if you think about, if you remember that slide I showed you, that when does somebody present with malaria, What you're really trying to do is some of these drugs work by sort of doing insipid treatment. When the person first gets their low-level malaria 3 weeks after the trip, if they have drug floating around in their bloodstream, you can nip it in the bud before it establishes as a high-level infection. And so that's why you take many of these agents for a month after you come out. The reason why we do only 7 days with the topical is because it has some effect directly on the hepatic forms. If you go back to doxy for a second, it's the typical side effects of doxycycline or the tetracycline, some photosensitivity, some candidiasis, some, if you take an empty stomach, some nausea. It costs about $2 to $10 a tablet. There's wide price variability, but you would avoid it in children in pregnancy. Mefloquine is another agent. This one is a weekly one, so that has the advantage. But when you actually do the math, because you take it starting 2 weeks before the trip, weekly while you're there till 4 weeks after you leave, when you do the math, basically Malarone for a typical trip of 10 to 15 days or so comes out to be roughly the same. But it really depends on the person's insurance coverage and availability. One of the things you have to recognize is that mefloquine has in about 1 to 3% of people neuropsychiatric adverse events. That can be anything from nightmares to sleep disturbances. However, recognize that it also is technically an FDA black label drug. This was issued, actually the manufacturer requested this because they were so tired of various suits being brought against them. And when the FDA issued their black label warning, it says that once you take this pill, you could have any neurological or psychiatric event at any point in your life. And so that's a pretty broad label. And so it means that if you gave somebody for a trip their mefloquine today, but then 40 years from now, they develop dementia or psychosis or depression, technically under that label, you might be liable. So if we give this drug, we do tell the people that it is a black label drug so that when they get to the pharmacy, you don't get the panicked phone call that because the pharmacies are required to report a black label drug to the person picking up the script. You don't want to get that frantic phone call trying to say, why are you killing me? We also get a formal consent form saying that here's the label, and if you're going to take this drug, we've gone over why we think it's the best drug for you. All right, then another agent you could use is chloroquine. The downside of chloroquine is you have to really use it in specific areas of the world where there's only chloroquine susceptible malaria. So that would be like, for instance, Haiti is a place like that, or there's a couple of other areas where there's only chloroquine sensitive malaria, and so you could use it. But those are not that common. Some of the side effects with chloroquine, it can cause a psoriasis or porphyria flare, and it can cause some itching and urticaria, especially in darkly pigmented individuals. It also is about $10 a tablet, and you can use it in adult and children. And it is considered safe in pregnancy. So it is the drug of choice if you're traveling to a chloroquine-sensitive part of the world and you're pregnant. Then you move into some of the other drugs called primaquine. Primaquine can be used for primary prophylaxis, especially where areas are primarily P. vivax because it has a liver effect. And you can also use it for what we call presumptive anti-relapse therapy. So for primary prophylaxis, you would start this daily, beginning 2 days before the person enters a malaria zone, and take it to 7 days after they're leaving. Like all the primaquines can cause some nausea and empty stomach. Right now, there's not a lot of availability of this agent. The most important thing you need to remember as a clinician is you cannot prescribe this medicine until you confirm that the person has a normal G6PD, because it can cause hemolytic anemia if they don't. And do not use it in pregnancy or breastfeeding, because even if the mom is G6PD normal, we don't know the status of the in utero baby, et cetera. And young children don't tolerate the meds particularly well also. So for all those reasons, there's a lot of limitations on the practical use of this. But theoretically, there might be indications where you want to give it. You can also technically give it in what we call presumptive anti-relapse therapy. That's if the person traveled to a highly, say, Vivax endemic area of the world. You can give this for 14 days after the person has left the trip as opposed to while they're there. But it's rarely done. And to be honest with you, all the studies were done while the persons were on other agents as well. So a lot of people recommend if you're going to do this, that they should be on chloroquine or something else at the same time. So at a practical level, that's not done too commonly now. Then there is another agent called tefenaquine that's a derivative or a corollary of primaquine, and that's FDA approved in the United States with 2 different drugs, and there's technically separate indications for them. But you can use this as a prophylaxis, and the hope was that, you could take this once a week, and it would be sort of like a mefloquine once a week, so compliance might be higher. But at the end of the day, at a purely practical level, it's expensive, all things considered, and you still have to do the blood test. So all the warnings that I talked about of GI upset, normal G6PD have to be done. And then if you actually look at it for primary prophylaxis, it's a 200 milligram loading dose taken daily for 3 days before leaving, say, the US, then weekly while you're there, with a final dose 7 days after you come back. And it's about $20 per 100 milligram tablet. So that's about $40. That's $120 for the first couple of days, and then $40 per week for the duration of the trip. So when you actually do all that math, it doesn't really save you much. And you have the issue of you have to do a blood test and bring the person back to clinic. All right, so those are the agents. So once again, the workhorses tend to be atovaquone, proguanil, doxycycline, and mefloquine, and chloroquine for certain areas of the world. Well, how do you figure out which drug you want to actually give to somebody? And there's a wonderful resource, which is the CDC Yellow Book. Here's the most recent one. There's a new edition that'll probably come out in the next 9 to 12 months, I suspect. And on this one, the nice thing about this is you can get a copy for like $14 and have it in your office, but you can also use it on the web. And actually, here's the little info site information. You just have to go to the web page and click on table of contents. And once you go to table of contents, you can see the entire book. And so you can put in, here's an example of somebody going to Nigeria, and you can go to the dictionary page for Nigeria, and you'll see that there's malaria all throughout the country. And there's drug resistance there with chloroquine. And the vast majority of species that are diagnosed there are falciparum malaria. And these are agents that could be used for somebody traveling there. So that's a wonderful resource that puts it right at your fingertips. Nigeria is pretty simple because it's holoendemic for malaria, but I'll show you some examples where you might have to go down a bit more in the weeds. Now, another resource I want to tell you about is this PrEP tool that's been put together on the Heading Home Healthy webpage. And this is supported through the GTEN program that Dr. Coyle mentioned, and it's supported by the CDC. And there's 2 portals here. One is for travelers, but there's one for the clinician. And this is really to guide the non-expert provider quickly through what they might want to consider for a traveler. Because, sure, you just saw that list on the previous slide, but how do you decide for this patient, what do I want to actually give or not give? So I'll take you to here. Here's the PrEP portal at the Heading Home Health, and you put in some things about you, and then you go right to, what I put in was a 24-year-old pregnant VFR female traveling to Nigeria, and it actually spits it out for you. It takes you through, and it says, right, this was just done. It says, right now, the CDC recommends all non-essential travel to Nigeria, and that's because of COVID. But there's lots of warning boxes. This is a pregnant individual, so they tell you about which vaccines you might want to do or not do. That's not the purpose of what we're here for today. But if you notice for malaria, it doesn't list all the drugs. It actually tells you mefloquine. And the reason why is because there is no chloroquine-sensitive malaria that we wouldn't use chloroquine for Africa. She's pregnant, so you can't use primaquine or doxycycline or tefenaquine. And because she's pregnant, the drug of choice would be mefloquine, since that has the best safety data in chloroquine-sensitive zone, chloroquine-resistant zones. While atovaquone proguanil is technically a category C, but mefloquine had years of being the only agent around, so there was a pregnancy register. And the CDC's formal statement is mefloquine is safe during the 2nd and 3rd trimesters of pregnancy, and probably safe during the 1st trimester. So it takes you right through what would actually be recommended for your traveler. And on that webpage also, there's in 14 languages, there's handouts you can hand to the individual in all different languages about how to stay healthy if you give them anything for GI issues, insect issues, hand washing, etc. There's all different things here that you can help them, and they can put in their pocket and bring on the trip. And on that webpage also, you'll see there's for the clinician, there's all different resources. You can print out the posters for your waiting room. There's free. There's lots of resources available in different languages. There's educational videos, etc. All right, so that's just to tell you that resource is available for you. And if you want to practice in different languages yourself, if we have any French Canadians on the phone, etc., you can switch into French. The entire thing is in French, and the entire thing is in Spanish as well, depending on your language that you want to practice on. All right, then post-travel, that was pre-travel. If you have any questions, maybe just type them down now and put them in the chat box or something, and we can come back on the pre-travel side. So on the post-travel side, here's an example. I'll do a case-based discussion. So we have a 42-year-old gentleman who you see post-travel, who was born in Nigeria, has been in the United States for about 16 years, and returned to Nigeria to visit family and friends. He was there for a wedding, VFR traveler, and he was there for 4 weeks, stayed with family, etc. And he did not seek any medical care before his trip because he was going home, and he did not take any pills or get any vaccines. He reports malaria and typhoid multiple times as a child, and in Nigeria, only children get malaria, so he wasn't worried about it. And he now works in IT in the United States. About 3 weeks after he comes back to the United States, he has some headaches and chills and muscle aches and some loose bowels. He thinks he maybe picked up a bug or picked up something from his kids. After about 3 days, he feels sick enough that he seeks medical care. You see him and he's afebrile, blood pressure a little soft, but okay, maybe a little close to tacky, but okay. He's a bit dehydrated to exam. There's no rash, lungs are clear, and your exam otherwise is pretty unremarkable, no hepatosplenomegaly. So you have somebody with a flu type illness, even though he's afebrile in your office, recognize that's just a single snapshot in time. And so he's already telling you he's having chills and headaches and muscle aches. So that's an infectious disease still proven otherwise irrelevant of whether he's febrile when you see him or not. So you think, oh, maybe this could be malaria. He's back from Africa. Maybe it's typhoid. Maybe he picked up some sinusitis or a GI bug. There's all different possibilities. There's a whole long list. We don't have time to do them today, but this is a pretty standard post-trip evaluation in a post-travel clinic, et cetera. So you do some routine things. You check some SMAC7 and you notice he's a little hyponatremic. Interestingly, his bicarb's low. That's a warning sign, right? Creatinine's up a bit, GFR is down. He's a healthy young guy otherwise. Billies are up a bit, platelets are down a bit. So first of all, these are all warning signs, right? You don't send this guy home. You don't have a diagnosis yet, and you have acidosis, and you have thrombocytopenia. So this guy does not go home. So if you're seeing him in the office, it's time to ship him over to the ED. Or if you're seeing him in the ED, you got to figure out what the problem is before you send him home. So maybe it's typhoid, so you send your blood cultures, although typhoid with acidosis would be really atypical. Maybe it's lepto or leptospirosis or something, so you might want to check a UA. But what are we here today discussing? We're discussing malaria. So you have to do some sort of malaria test. And to be honest with you, the malaria test that most places use now is sort of the rapid antigen test, just like we hear for COVID, et cetera. And the one that's FDA approved in the United States is Binax Now. The other test that you can do, and it's sort of just, this is just a pregnancy test that a lot of labs do. And depending on if you get the bands, and so he gets a band, he has a classic pattern for Plasmodium falciparum. And so, and then you can go on and do a thin and thick smear at that point, both to confirm the diagnosis and to get a parasitemia level, because that's going to help you figure out how you're going to strategize for treatment, et cetera. And so here's his peripheral smear, and you see classic falciparum malaria in the individual with the pleak form and sort of the headphone sort of signals, et cetera. And the lab tells you he has a formal parasitemia of 1.7%, and it's Plasmodium falciparum. So do you admit or not admit? In the United States, admit falciparum malaria. I'll just make it simple, right? Because you don't want this person to go south on you quickly. You want to gain control. Many of the meds you use, most pharmacies don't carry. So if you just give him a script for Coartem and send him out the door, he probably is not going to fill it. He's probably not going to find a pharmacy that's able to fill it. It might be too expensive for him. Falciparum malaria gets admitted. If you want to maybe consider some of the lesser malarias, Vivax, Ovale, et cetera, you could maybe consider sending the person home, but I personally recommend it. I personally bring them in for at least 24 hours till we make sure we have the person going the right way. And so you admit them, and how do you treat? So before you figure out how do you treat, you have to answer these questions. And I'll share these slides with Professor Coyle, and she can post them on whatever the web pages are. And so, you know, which malaria species, where do they get in the world? What's the parasitemia level? Is this an immunologically naive or partially immune individual? Do they formally classify for severe malaria? Do they have comorbid conditions? And are there collateral issues, et cetera? You know, what's their housing situation, et cetera? These are all things that you have to figure out. So let's just do a bit of global epidemiology. So we talked about that the primary burden is in sub-Saharan Africa, and I'll point out again sort of the PNG area of the world. And those are areas where the malaria burden is highest. If you actually fine-tune down to that on falciparum, here's the large burden for falciparum over here and over here, and there's pockets in Latin America. And if you look at Vivax, individuals are much more likely coming back from Asia, although you can get falciparum malaria in these areas of the world. The burden is more likely to be, say, Vivax in some areas of Africa, Vivax, and some areas of Latin America, Vivax is the primary risk. So you won't know which one they have. You have to be pretty sure of what their species is. And the take-home message is don't overthink it. If you can't figure out what their species is, treat them for falciparum. It just makes it simple. And so here's like that image that I was talking about. Well, what if they had come back from Brazil? Well, there's areas that have malaria. Those are in the red. There's areas which is a lower risk, and the CDC would just recommend precautions. And there's areas that are not particularly risky. You have to figure out where the person was. And this is just taken from the CDC web book, where you have countries that might not be holo-endemic. And here's another area that's not holo-endemic. If the person had come back from Southeast Asia, there's actually areas of, say, Thailand that don't have malaria, other areas that do, et cetera. And here's the gory details to help you. And even if you use the prep tool, it'll link directly to this dictionary page. So for instance, if the person was in Thailand, or you're prepping them for Thailand, you can actually go down and they'll actually give you the specific provinces. So you can actually fine tune the trip and figure out, is this somebody who needs to take pills or not take pills, et cetera. So let's go back to our patient trying to pick your drugs. Well, there's a whole bunch of resistance profiles, both for falciparum and for Vivax, including now we're getting artemisinin delayed clearance, both in Southeast Asia. And you probably saw the New England Journal of Medicine article about 2 weeks ago of it being reported in sub-Saharan Africa. This area of the world over here in Southeast Asia has the highest resistance that we worry about now, because it also has mefloquine resistance, et cetera. But don't overthink it to some, and the green areas of the world are areas where there's chloroquine susceptible malaria. So if you had somebody back from those areas, you could maybe treat them with chloroquine, et cetera. But I'll make it even simpler. Here's the zone of the really high level that we worry about. I'll just make it simple for you. So you go back to your page, this guy's back from Nigeria, there's chloroquine resistant, so you know you're not going to use that. But just about 3 weeks ago or so, the WHO changed its recommendation and now recommends artemisinin-based therapy for everybody with malaria. There is an exception to that, which is if you're in the first trimester of pregnancy from the WHO perspective, and it's a chloroquine susceptible species, you could use chloroquine on theoretical grounds. However, basically, they just want to make it simple. Everybody around the world with malaria should be getting an artemisinin medicine. It should be a combination medicine, and your big decision is whether you're going to do whether it's intravenous or parenteral or whether it's oral. So to answer that question, and I should say the CDC, though, still breaks it down into whether it's chloroquine susceptible or not. So it'll be interesting to see over the next 6 to 18 months if the CDC changes their recs. So right now we're in this nebulous zone, but I wouldn't overthink it. I would say it's falciparum malaria. It's obviously chloroquine resistant. This guy has a parasitemia of 1.7. He's probably partially immune. So then the next question is he severe or not? And here's the formal definitions of whether somebody's severe. And a lot of it is just clinical gestalt, right? If the person's having seizures or is unconscious or is in shock on multiple pressors or going into ARDS or has persistent acidosis. Now, remember, our guy had a single bicarb of 15, but maybe if you perk him up and give him some IV fluids, et cetera, is it still 15 or does it perk up to 23? In which case that's not persistent acidosis. Is he in renal failure? Is there bleeding? And is there severe anemia? And then we use it, the cutoff of 5% parasitemia for falciparum malaria. And that's because remember that the vast majority of parasites in someone who has falciparum is not in the peripheral bloodstream. They're actually docked in the postcapillary venules. So when you see Vivax malaria of a parasitemia of 12%, 12% is bad, but you're seeing what you got. When somebody actually has 6% falciparum malaria, they're probably closer to 35 to 40% of their red blood cells are infected because the majority are not in the peripheral bloodstream. So that's why we use 5% as a defining definition for severe parasitemia. And if you need hard numbers, if you're somebody who wants really hard numbers of what's the formal definition of those various things, here you can see the formal definitions there. And the reason I'm belaboring this point is because the treatment for uncomplicated malaria now in the United States should be Coartem. I don't want to hear I use Malarone. I don't want to hear I use mefloquine. Those are all second or tertiary drugs, right? Right now, studies have shown that the artemisinins are the best drugs. They have the most rapid parasite clearance and they have improved survival. So if you're giving any other agent, you're giving a second line agent. So if you, at your practice, at your pharmacy, you have to have access to Coartem for your uncomplicated malaria. And if the person meets the formal definition for severe malaria, then you need to give them intravenous artesunate. Now that's available through 2 mechanisms right now. It's available through an IND with the CDC, but many people on the phone are in New York. In New York, you have such a burden of malaria, your hospitals should actually stock this drug. It is now commercially available over the last about 6 months or so. And those agents are listed here. You can go to the CDC webpage for both the definition of who you can use this drug in and the commercial availability. So for instance, here at my hospital, Mass General, we now have this on formulary and we have in stock this agent because we are the Northeast Region 1 for HHS, and we get a lot of the Boston cases because we're right across from the airport from Logan, et cetera, as well. So it's FDA approved. You can get this drug on your formulary. And the one, if you can't get on your formulary and you have a patient tomorrow and you don't have it on your formulary left, you can call the CDC, available 24/7. They'll chat with you. The medicine is parked at a number of locations across the country, and they have a pretty good record of getting the drug to you within 4 to 6 hours on average. So you have to figure out where you are and what's the logistics, et cetera. But on average, the drug, it will get to you pretty quickly. But recognize also that my understanding is that the CDC stock will expire next summer, and it won't be available through that IND anymore. So we're down to about 8 or 9 months for you to get this on your formularies, or you won't have access to this drug. Here's how artesunate is given. It's given as a mg per kg per dose and 3 dosages, and then you check the person's parasitemia, and if it's still greater than 1%, you redose to a maximum of 7 days. And once less than 1%, you complete using an oral course, and the oral course would basically be coartem, etc. One of the side effects we see with the artesunate is that it can lead to a delayed hemolytic anemia. So anybody that you treat with malaria, once they've buffed up and you send them out the door, if you've given them an artemisinin, especially artesunate, then you'd need to see them in clinic or have a follow-up blood test done on 7, 14, and 30 to confirm that they're out of the woods for developing that. Some of them can be quite severe hemolytic anemia, transfusion dependent, especially the individuals who are immunonaive and had high-level parasitemia. Those are the highest risk individuals for that. And once again, the CDC has 24/7 support for you for malaria, and there's always somebody on that you can chat. But obviously, this individual could prevented all this by just being on some medicine and taking some simple precautions when he was overseas. So I bring you back to, print out these posters, put them up in your waiting rooms, use these tools, etc. And maybe I'll stop there, and I will stop sharing, and we'll see if there's any questions in the chat.
There are a couple of questions in the chat. The first one is about if there is a maximum period of malaria prophylaxis that you can provide to a patient.
Yeah, the quick answer is no. The quick answer is you could. I mean, in the old days, Peace Corps individuals are, who serve overseas for 2 years. You can take the drugs for a prolonged time period. Really long-term high-dose chloroquine, but really not the dosages we're dealing with. Because remember, people take chloroquine and hydroxychloroquine on a daily basis for a bunch of rheumatological conditions. But if someone's going to be really long-term on high-dose chloroquine, that's something where you want to do an ophthalmological exam on a 12-month basis, etc. But at the practical level, no, these meds can stay on for a very long time period. I can tell you that most of the expats, when they go overseas, they get in the habit, they often take meds until they get comfortable in their zone and they have access to good, reasonable medical care, etc. And if there's a specific mosquito season or malaria season, many of them go on or off depending on what the burden is where they are. That's not formal CDC recommendations, that's just what a lot of people do practically.
The next question is in terms of your perspective in terms of standby treatment for malaria compared to chemoprophylaxis.
Yeah, so what the questioner is asking about is another philosophy, which is more prevalent, say, in European countries, is, well, why have all these people taking all these meds that they don't really necessarily need at an individual level, although it makes sense maybe at a public health level, and why not just wait for the person to figure out if they get a fever or not, and then they can take some meds? And the answer is that in some individuals, we do that, especially if it's a healthcare worker working overseas in a low malaria zone, etc. But the reality is there's a lot of causes of fever. And for people to be popping drugs, and then you can say, well, they can do a rapid test on themselves. Well, studies have shown that the rapid tests, when somebody's febrile and feeling sick and they're not medically trained, the rapid tests are often inappropriately done or inappropriately interpreted. And then if the person, they actually might have typhoid, or they might have Lassa fever or leptospirosis, and they end up feeling, I've ruled out malaria, when malaria actually wasn't their problem. So we just would avoid all this to begin with, and when some individuals we would recommend doing it, but they tend to be healthcare workers working long-term overseas.
Gotcha. The next question is your thoughts in terms of compounding for kids.
Yeah, so I guess the question is, so compounding pharmacies can work. I can tell you what we do at a practical level, because I do both pediatric and adult. So we do at a practical level is the two drugs that we usually use in the young kids are either the pediatric tovacone proguanil and or mefloquine. And there's reasons for using one or another. Mefloquine is weekly and all that sort of stuff. We go over the nightmare and everything issues with the parents, etc. Of those two agents, we just tend to tell the mom or dad on the mefloquine side just to get a ballpark. It's scored. So if you're going to end up on, 50 milligrams, we just round it off and we tell them how to cut the tablet. And we tell them to crush it with a spoon, and all the malaria drugs are bitter, and we tell them to mix it with something sweet. You could technically send that individual to a compounding pharmacy. However, I'm not aware of any studies showing that any of the tricks that the compounding pharmacies do increase or decrease bioavailability outside of what the mom and dad can do on their own. So it's a bit of a data-free zone, and we don't usually jump through that hurdle. We just tell them to either take the pediatric size tablet. If they want to crush it, we have them crush it, or we do a scored mefloquine and have them crush it as well.
Gotcha. The next question is, have you ever used part or terminal prophylaxis for any of your patients, and in what context?
Yeah, I personally don't do terminal prophylaxis. I just view it as well, I guess, I mean, so on the anti-relapse therapy, I really don't use. On a separate issue is for individuals who've had confirmed Vivax or Ovale malaria, once you treat them, do you try to clean out the rest of the liver? And if there's not a contraindication, I do try to do that, because about 15 to 20% of those individuals, once you get through their first episode of Vivax, will have a second or third episode of Vivax, et cetera. And so I usually do try, unless the person's G6PD deficient or something, I do try to clean out the liver in individuals with confirmed Vivax malaria.
Perfect. Have you used dafenoquine? It has a long life. The repeat weekly dosing was new to me.
Yeah, so I personally have not prescribed it yet, largely because of all the reasons I just listed, meaning it tends to be pricey, it tends to be hard to find. When you add it all up, I'm not sure it actually adds a lot, and you have to do a blood test before you do it. But it is, I mean, I'm always welcome to new agents on the market, because there might be niches for it, but it's certainly not the panacea. I mean, you know, I think when we all heard about it for the first time 15 years or so ago, we sort of thought, oh, you know, maybe the person can just take this pill once and be protected for 3 to 6 months or something. And the answer to that is no. Although I will point out, just FYI, to do a total paradigm shift, I think people probably saw the New England Journal of Medicine article, I think it was a month or two ago, of a monoclonal malaria antibody that protects you for 3 to 6 months. And it might seem strange to think about, would somebody get a monoclonal antibody before the trip, but it works, it looks like, and people are getting used to giving monoclonal antibody for COVID. One could imagine that the travel clinics 5 or 10 years from now might be giving you a dose of monoclonal antibody in the clinic, and then you don't have to worry about taking any pills when you're overseas or so. So more to follow on that. It was an interesting article about, I think it was about a month or two ago in the New England Journal of Medicine.
Oh, interesting. The next question is, this is for severe malaria. What do you do while waiting for the IV artesunate? Do you give any second-line agents?
Yeah, so the answer to that is yes. So if you have Coartem, ideally we try to get Coartem into the person. You know, so if they're sitting there, you're in the emergency room, they have a bicarb of 12, they're sick, and you know, first of all, if you have artesunate in your formulary, great. You know, you can get it into them in the next hour or two. Let's just say you don't, you've called the CDC and the CDC says, you know what, we can't get it to you tomorrow morning because of the logistics that are involved. What do you do tonight? Well, if you have Coartem, give them the Coartem, right? Start something, because you want to start bringing them under control. So, and if they're unconscious, drop an NG tube and give them the Coartem that way. And if you don't have Coartem on your formulary, wherever you're practicing, that's when you can fall back to other agents. But, you know, I mean, if you don't have Coartem on your formulary, you probably don't have quinine or one of those. You're probably down to clindamycin and Malarone, et cetera. You can give those to hold the line tonight, but they're really second and tertiary line drugs. So, but definitely you want something into that person within an hour or two.
Gotcha. And in the same line, if you have a patient, does it with severe malaria because of the parasitemia level, do you trust in any kind of partial immunity, or you just treat it as severe malaria by default?
Yeah, so the answer on that is, I guess the fine point, clinical fine point on that is that non-immunes can get sick as dogs with a parasitemia of 0.5%, 1.2%, et cetera, where people who are partially immune, they'll be sitting there and yeah, they feel a little fluey and everything, but they come back with the 4 to 7%, et cetera. When you see a 4 to 7% in a non-immune, someone born and raised in, say, Wichita and went on safari and got malaria or something, if you see a 4 or 7%, they are going to be sick as dog and probably in your ICU. So the take-home message there is that the partially immunes appear a little less sick and are probably a little less likely to go south on you, but they can easily go south. And the first thing I look at is a bicarb and a lactic acid. because that tells me what's happening at the end organs, right? So if their lactate is 4 and they have a bicarb of 12, I don't care what their parasitemia level is. I don't care who they are. I know that they're not perfusing their peripheral tissues. And to me, that's severe malaria. And so in those situations, make sure that you look at the bicarb and get a lactate as quickly as you can. And if they're elevated, those are the people who are going to crap out on you in the next 6 to 12 hours.
And just following on the same line, how frequent do you trend the parasitemia?
Yeah, so we tend to trend at least once a day, right? And part of it is because it requires, so if you're trending the parasitemia, that requires the lab can actually do a parasitemia count. If your hospital sends it out, you're looking at 1 to 2 days till you actually get those data. And even here with us, we have somebody who can read the parasitemia up till about 9 o'clock at night, but then we don't get the next person in until 6 o'clock in the morning. And so at the end of the day, you're often dealing with yesterday's numbers. So that helps you, but does it really help you if you have 3 from yesterday? Because you're not going to see them until tomorrow anyway. So I tend to do it every 12 hours or so for the first day or two. And it's not so much that I get those data in real time, but I can at least see the trend that's occurring. And then I do it daily after we've gotten them going in the right way. Perfect.
The next question is, do I count 7 days from the start of coartem administration or at the end to make another blood test?
So the coartem itself, I think I'm understanding the question. You can do intravenous for up to 7 days, is the way the drug is technically approved. This is artesunate now. But presumably you're going to be changed over to orals. To be honest with you, I've only had one patient that we've had to give more than 1 course of artesunate to. And that was somebody who we couldn't get the parasitemia level down because they started so high to less than 1% with those 3 dosages. So the answer is the vast majority of people will fall. That's the beauty of artesunate. They will fall very quickly. And so it's unlikely, but possible that you might have to give, 2, 3 courses, etc. on that one. When you switch over to coartem, you do the normal treatment course for coartem. And that's a funky regimen where you take a bunch of pills today, then you take it 8 hours after that, then you take it 12 hours after that, then you take it at 24 and 48 hours. So it's a funky regimen. So gone are the days where you used to put them on, say, clindamycin and quinine for 7 days or something like that. We really don't do that unless it's bizarre situations.
Perfect. And the last question I have here is, are any of the drugs synergistic between them?
And the answer is yes to that, meaning, so when you do artesunate, we don't put a second agent on. But if you think about it, when we do some of the drugs, I guess the question is actually high level, meaning which ones are just you're co-treating for an additive effect and which ones are synergistic. I'm not sure that true synergy has been shown necessarily for these combos, but we use the drugs in combo largely because in case we're trying to down select from resistance developing and on the chance the person has resistance. Now, there are some drugs where there is true synergy. And for instance, if you remember, I gave that comment of if you are going to mop somebody up with primaquine after their trip, all those studies were actually done on people who were already, say, this is back in the 50s and 60s and 70s. Those are all done when people were on other agents as well, like chloroquine, et cetera. And actually, if you only give primaquine without chloroquine on board, it's not as effective. So there's obviously at least an additive, if not a synergistic effect on how those agents work, especially on the hypnozoite forms.
Perfect. I have 2 more questions. Is there, besides the cost, is there any other downside of taking Malaron for a long term?
If you're taking what, Lariam?
Malaron, if there is
any
Malaron. Downside of taking Malaron.
I mean, the main, I mean, I guess anything can happen with anything, but remember Malaron is 2 drugs. One is atovaquone, and we know that people can take atovaquone for a really long time when people have, PCP prophylaxis, et cetera. So, and it seems to be relatively safe, although it's a category C. The main side effect and then the other one is proguanil. Proguanil is an old drug that was used for years with chloroquine, especially in Europe and the UK, et cetera. And the drug is also known to be very safe, including safe during pregnancy, et cetera. One of the side effects, once again, like you get with proguanil with a long-term use, is those aphthous ulcers. But the majority of those individuals actually, it goes away in 1, 2, or 3 weeks. And so if they just make it through, 1 or 2 weeks, and that's the drug that you want to do long term. And obviously anything can happen to anything. Someone can develop a hepatitis or a drug reaction to anything. But as a general rule, one of the reasons that we don't tend to use Malarone for really long time is because of the price, right? If someone's going to be overseas for a year, right, and they have to take an atovaquone proguanil every day at $10 a tablet, well, why not just switch them to Doxy, where they might be able to find a pharmacy where they can get it for $2 a day, or even cheaper, right? Because that saves you, because that benefit of, they have to take a month of Doxy after they come back versus a week of Malarone. Well, that may make a lot of sense in the short-term traveler who's going overseas for only a week or two. But if someone's overseas for a year, those extra 21 days doesn't make a difference, right? So the long-term travelers, we tend to try to default to doxycycline unless we think compliance is going to be an issue, in which case we try to default to mefloquine if we go over the pros and cons. And the reason there is because mefloquine buys, it's only once a week, and mefloquine also buys you that if you forget to take it on Tuesday, well, it has a long half-life. That's why it's weekly. So if you take it on Wednesday, you're okay, or Thursday, you're okay. But if you're taking a daily drug, the reason we give it daily is because there's a short half-life. So if you're supposed to take it on Tuesday, but you don't remember to take it till Friday, well, you had a window there where you're at risk. So there are so if the long-term people, we tend to use Doxy or mefloquine, or chloroquine if they're going to be in a chloroquine susceptible part of the world.
And the last question I have is, they want to know your comments in terms of malaria in patients with diabetes, if there is any increased risk for these patients, and if metformin in any way can have a protective impact since it's similar to proguanil.
So I guess we turn to the first one. I'm not aware that individuals with diabetes a priori are at any increased risk of malaria per se. I guess there might be some mild effect on if, the answer is no. I'm really not at a practical level. We don't think that changes the risk appreciably. With regard to the second agent, now they are at risk because of their comorbid conditions. They're more at risk of going south on you if they get malaria, right? Because they probably have, they might have some diabetic dysfunction of their kidneys, et cetera. So they're more likely to run into complications from their severe malaria and their their vasculopathy, et cetera. With regard to metformin, I haven't seen any formal analysis of that. I can tell you that proguanil alone is not effective, right? So I would imagine that if metformin is a step down from proguanil, that, maybe it's giving them a little icing on the cake, but I certainly wouldn't rest on it. And it's not an approved drug for that. And let me just say, I'm just looking at the chat to see if there's anything else we haven't covered. And I see someone wants to know about the slides. Yep, right after this, I will send these slides to the organizers and they can post them however they're posting all the other things. I think we've given that. Cesar, I think you've asked all these.
Yeah.
Perfect. So we're working off the same list. Excellent. And they're right. I mean, someone did say, photosensitivity with Doxy. You're absolutely right. But I use it as a way to sort of, if I do give Doxy to somebody, I always do say, well, you should be taking sun precautions anyway when you're overseas. You should be wearing, sunscreen and a hat, etc. This just makes, this just reminds you not to forget to do that. But individuals should be taking sun precautions anywhere in the world. I'm so tired of taking care of people with melanoma. They really should be taking sun precautions. Well, great. Well, I think we finished about 5 minutes or 6 minutes or so early, but hopefully everybody can use those 6 minutes. 6 minutes well. And what it says is, how do you treat for delayed falciparum clearance? So I guess on that one, once again, I assume what you mean is, let's just say you have somebody back from sort of an area of the world. We haven't really seen delayed falciparum clearance, if you think about it, in the United States yet, because you're going to be treating those individuals with IV artesunate if it's severe, and then you're going to be treating them with Coartem after that. If you do have somebody who still has parasitemia, say at 7 to 10 days into treatment, then you're looking at a probably resistant strain, or somehow the med's not working in them, but they're not taking it, or GI availability issues, et cetera. And that's when you should be in touch with the CDC and your Department of Public Health to try to get the hands on those isolates in order to sort of look to see what's there or not. The other thing I will mention that prompted me to remember a question that I often get asked, which is somebody came back, you diagnosed malaria in somebody in the family, kid number one, and there was actually 3 kids and the parents went on the trip and none of them took any malaria chemoprophylaxis. And what do you do? And so the answer is you can do what we call post-exposure prophylaxis for malaria. The person's been out, we do it for only up to a month after the trip. And you treat them for up to a month, if that's making sense. So if they're back and you've diagnosed kid number 1 with malaria 1 week after they come back from Ghana, then we put the rest of the family on 3 weeks of a daily drug. And that can be daily doxycycline, or it can be daily Malarone. It takes a while to rev up mefloquine. There's a lot of loading, so we tend not to do that one. And the logic there is that because this family's at risk for malaria because one of them's already had it, and the horse is out of the barn to some level, so your Malarone is not a 1-week drug now, because Malarone works because you're taking it at the time of the mosquito bite and when the liver forms are getting set up. When you are falling back on post-exposure prophylaxis, you're actually falling on trying to treat those early infections in the bloodstream. And we sort of arbitrarily said 1 month afterwards, because you'll pick up the vast majority, 96% of your falciparum. So using that logic, if they're more than a month out, we do nothing. We just tell them if they get any fevers, they need to come right in to be evaluated. But if they're only a week out or so, we put the family on doxycycline or Malarone, and we give them daily up until 28 days after the trip, if that makes sense to you. And that's just trying to lessen that likelihood that somebody else in the family will develop malaria and present with you a day or 2 later. Perfect. Well, it's been wonderful having a chance to be with you, Aura. Dr. Berto, thank you for moderating the session.
Thank you so much, Dr. Ryan, and thank you everyone for your participation in these breakout sessions. As a reminder, please join to the talk of Dr. Gerard Flaherty on education in travel medicine. What can ISTM do for you? Which is going to start immediately after this breakout. You can look for the Zoom in your agenda. Thank you so much.
Bye-bye, everybody.